Hello everyone, my name is Zachary Gruce, and I'm one of the PGY1 pharmacy residents at Wake Forest Baptist Health. My study is an assessment of new-onset diabetes and metabolic effects associated with integrase inhibitor-based antiretroviral therapy. Before I begin, I just want to mention that my co-investigators and I have nothing to disclose. The treatment of HIV with antiretroviral therapy has been associated with reversing the underlying hypermetabolic state of HIV infection, which has been correlated with an increase in weight gain, particularly in those that are receiving integrase inhibitors or INSTI-based antiretroviral regimens as compared to others. However, our study team wanted to evaluate if this weight gain correlates with new-onset diabetes. Thus, the primary objective of the study was to assess the risk of new-onset diabetes caused by INSTI-based antiretroviral regimens, and then to assess the risk of metabolic adverse effects associated with INSTIs compared to other antiretroviral regimens. This study was a retrospective, observational, single-center cohort based out of the Wake Forest Baptist Medical Center Infectious Disease Clinic. Patients were identified by a report of all those that were prescribed antiretroviral therapy while being seen at this clinic. Using a random number generator, patients were randomly selected for inclusion. The electronic medical record was then reviewed to collect patient-specific information such as what's listed below. The unique aspect of this trial was that patients were classified into exposures. Exposures were defined as the time from the day an antiretroviral regimen was prescribed to the following minimum of 6 months and maximum of 24 months of therapy thereafter. Patients were then classified into different regimens based on their non-NRTI component of the regimen, including INSTIs, PIs, or NNRTI-based regimens. Thus, if there were changes in a patient's antiretroviral regimen in regard to the individual components, they could be included in this study more than once. In order to be included in this study, patients had to be at least 18 years of age and have a confirmed diagnosis of HIV infection while receiving care at the clinic between the dates listed below. Once again, patients had to be prescribed the same antiretroviral regimen for at least 6 consecutive months. Patients were excluded if they had a diagnosis or if they were receiving a medication commonly used to treat diabetes or prediabetes prior to the initiation of antiretroviral therapy. They were also excluded if they were receiving select medications known to cause hyperglycemia, insulin resistance, or impaired glucose metabolism within 3 months prior or during the antiretroviral exposure. New-onset diabetes was primarily defined using the American Diabetic Association's, or ADA's, definition of new-onset diabetes, using the first 3 bullets on the left side of the screen. However, there was a modified fourth definition of greater than or equal to 50% of the glucose readings being greater than 140 milligrams per deciliter for patients that may have been admitted at some point during their exposure. This threshold of 140 was chosen because an average glucose of 140 correlates with an A1C of about 6.5%. New-onset prediabetes was defined using the ADA's definition, and then there were other secondary outcomes such as hypertriglyceridemia, which was defined as triglycerides greater than 250 milligrams per deciliter, and then median changes in the various variables below. Our sample size calculation determined that we needed 190 patients in each group, and we used the following statistical tests to evaluate differences in baseline characteristics and outcome measures as appropriate. All of the exposures are included in the first column of this table. However, there are some patients that received at least 2 of the following, INSTI, NNRTI, or PI, which are not represented in their own column due to low representation in this cohort. On average, patients were about 42-year-old males. In the integrase inhibitor arm, there were more African Americans. The average BMI was 25.8, and at least 1/3 to 1/4 of all participants had a cardiovascular disease at baseline. When evaluating pre-exposure lab values, there was no true difference between the 2 groups. However, those that received integrase inhibitors did have worse lipid panels at baseline. When looking at pre-exposure HIV viral loads, or CD4 counts, there was no true difference between the two groups. However, those that were receiving integrase inhibitor-based therapy were receiving at least their second antiretroviral regimen or exposure. More patients in the integrase inhibitor arm met the primary outcome of new-onset diabetes. However, this was not found to be statistically significant. Of note, only 1 in 19 of these patients met this definition by having a hemoglobin A1C greater than or equal to 6.5%. There was no true difference between the two groups in regards to new-onset prediabetes. However, there was a trend in increase in weight in the integrase inhibitor arm. There was a statistically significant increase in the amount of patients that met the definition of hypertriglyceridemia, or receiving a new medication to treat hyperlipidemias, or an increase in the intensity of the regimen that they were already receiving in the integrase inhibitor arm. When evaluating for individual variables that may be associated with the outcome of new-onset diabetes, there was no statistically significant increase in those that received INSTIs, PIs, or NNRTIs. However, there may be a protective effect in those that received TDF versus TAF. There was a statistically significant increase in those that were greater than 45 years of age at baseline, and a trend in that direction in those at a cardiovascular disease at baseline. There may also be a protective effect in those that achieve virologic success. When interpreting these results, there are some limitations to keep in mind, seeing as how this cohort did have a small sample size. As it was retrospective in nature, I was unable to confirm that all glucose measurements truly were fasting, and there were limited hemoglobin A1C levels that were ordered. There may be some underlying selection bias by the provider, seeing that more African American patients were prescribed integrase inhibitor-based regimens, and we were unable to adjust for confounding variables such as patients actively dieting and exercising. Despite these limitations, there are some conclusions that we can take away from the study, seeing that integrase inhibitors were not associated with new-onset diabetes or prediabetes. However, there may be some factors that are statistically associated with new-onset diabetes, seeing as how age greater than 45 remains a constant risk factor, and there may be some protective benefit in TDF in patients achieving virologic success. However, echoing recent literature, integrase inhibitors were associated with greater weight gain and, unique to this trial, hypertriglyceridemia. I want to say thank you to all the members of my study team for all their hard work that they put into this study. This is my presentation objective and self-assessment question, and I want to thank you all for taking the time to listen to this presentation, and please do not hesitate to reach out if you have any questions.